Hello, you are most welcome, ladies and gentlemen, to the Understanding Spirit of Anatomy on Tuesday Night Anatomy with Daniel Okwan. Today's section, we begin our revision looking at the upper limb. And this is going to be the first part. Now in this revision, I have some MCQs, some questions that I've set for you. I'm going to help you get the correct answers. And of course, those ones which aren't correct, yes, we justify why, they are incorrect. So please, if you've not watched, previous videos on the upper limb, you can visit the playlist to get all those videos so that you can get, better understanding, in this revision. And so, without much ado, let's set the ball rolling. And we begin this revision, part 1, with question number 1. And question number 1 says, which of the following is not true? Now, option A says, with the exception of the subscapularis muscle, the rotator cuff muscles insert on greater tubercle of the humerus. Yeah, that's a very true statement. You know the rotator cuff muscles, they are the steering muscles, of the shoulder joint, the glenohumeral joint. And of course, they are 4 and they are the 6 muscles, talking about supraspinatus, infraspinatus, teres minor, and of course, the subscapularis, muscle. Now, all those, muscles which we are talking about, the supraspinatus, infraspinatus, and of course, teres minor, those ones are going to insert on, of course, respectively superior, middle and inferior, facets, articular facets, which, are found on the greater tubercle of the humerus. Yeah, there's only a single facet, which of course the subscapularis will be inserting on what we call the lesser tubercle. So this option A is indeed true. Now option B says the pectoralis major and often pectoralis minor muscles are supplied by the medial and lateral pectoral nerves. That's a hybrid. Yeah, that's a very true statement. Now, usually what we are saying is that, yes, we will see that pectoralis major and of course pectoralis minor, both of them will be, supplied by, of course, the medial pectoral nerve. But sometimes too, we see that, apart from, now what we are saying is that pectoralis major and pectoralis minor muscles, yes, they are both supplied by medial pectoral nerve. But in addition, to the medial pectoral nerve, pectoralis major will also be supplied by, of course, lateral pectoral nerve. Now, sometimes pectoralis minor may also be supplied by lateral pectoral nerve. If you are seeing such a phenomenon, then of course these muscles become hybrid. So that's a very true statement. So that's very true. Now, option C says the trapezius and latissimus dorsi muscles are innervated by spinal accessory nerve. That's the cranial nerve 11, which runs superficial to the Levator Scapulae, Rhomboidios Minor, and Rhomboidios Major muscles. No, that's a wrong statement. The reason is that, yes, trapezius muscle, yes, will be supplied by spinal accessory nerve, no problem. In fact, together with what we call, sternocleidomastoid muscle and not latissimus dorsi. Latissimus dorsi will be supplied by, of course, thoracodorsal nerve or nerve to latissimus dorsi. You will see that. So that's this statement, this portion in this statement makes it wrong. But indeed, this spinal accessory nerve will run superficial to, of course, these 3 muscles, which are a bit deep to, of course, the trapezius muscle. Yes, they will, which are going to insert at what we call the medial border, dorsal aspect of the medial border of the scapula, yes, namely Levator Scapulae, Rhomboidios Minor, and of course, Rhomboidios Major muscles. Those ones, yes, the spinal accessory nerve will run superficial to them. With of course the dorsal scapular nerve, which innervates Levator Scapulae, Rhomboidios Minor, and of course Rhomboidios Major, actually running deep to these muscles. We will see that. So this is a wrong statement. So we've seen a wrong, correct answer. That's option C. That's a wrong statement in here. But let's move on. Option D says, apart from the dorsal scapular nerve, C3 and C4 ventral rami, yes, of the spinal cord, actually spinal nerves actually will supply what we call the levator scapulae muscle. That's a very true statement. Yes, we said that these three muscles, levator scapulae, rhomboidios minor and major, will be supplied by, of course, dorsal scapular nerve with root value C5. But what is happening is that levator scapulae also gets some nerve supply coming from the ventral rami, of these spinal nerve C3 and of course C4. That's also true. Now option E says thoracodorsal nerve, which is one of the terminal branches of the posterior chord, has C5, C6 root values. Yes, indeed, that it is one of the terminal branches of the posterior chord. Yes, no problem with that, of the brachial plexus. But what is happening is that its root value is not C5, C6. It's rather C6, C7, and C8. So we see that thoracodorsal nerve, not C5, C6. So it means that in this question, we have two answers, two are correct, and for that matter, two wrong statements. That's E, and of course, that of C. So let's justify these ones. So there we are. If we talk about rotator cuff muscles, yes, you don't need to forget that on what we call the proximal, aspects of what we call the humerus, proximal end of the humerus, upper end of the humerus. Then what we are saying is that we have greater tubercle and we have lesser tubercle. Now these two tubercles are going to provide, surfaces for attachment or insertion points to what we call the rotator cuff muscles, the steering muscles of the glenohumeral joint. And these ones, we say with the mnemonic SITS, S-I-T-S, the first S-I-T will be inserting on facet on what we call the greater tubercle. So we have what we call superior facet, middle, and of course inferior facet over there. So what we are saying is that superior facet for, of course, supraspinatus muscle, middle for what we call infraspinatus muscle, and of course, the inferior or the lower facet for the teres minor muscle. So this is how we are going to say it. And then there will be a single facet which you find it on what we call the lesser tubercle. Lesser tubercle of the humerus, and that one will be provide important insertion point for what we call the subscapularis muscle, clinical, which we call the forgotten tendon. Yes, whose tendon is called forgotten tendon. Yes, that's the subscapularis muscle. So that's the rotator cuff. So there we are, just trying to show you. So this is the subscapularis muscle, and this is the lesser tubercle. So the subscapularis muscle in the subscapular fossa, taking origin there, comes all the way to insert on the facet which is on what we call the lesser tubercle of the humerus. However, if you take what we call supraspinatus muscle, if you take infraspine, there's a spine of the scapula, and therefore taking origin above the spine, that's in the supraspinal fossa, will be what we call the supraspinatus muscle. And then below it will be infraspinatus muscle. Then of course, the teres minor muscle also comes in. Yes, all of them go in this way to insert on what we call the greater tubercle of the humerus. So that is actually what I want you to know. Yes, now we said that we have pectoralis, major muscle. Yes, pectoralis major muscle, we'll have two, or let me say 3 hairs actually. Yes, some books will say 3 hairs. That let me go with the 3. If it's having 3 hairs, then of course medial half anteriorly of this clavicle will give attachment to, of course, the upper head, which is actually the clavicular head. And of course the middle head being majority of it, the sternocostal head. And then eventually, if coming from the external oblique aponeurosis taking attachment, there will be what we call the abdominal head. But at the end of the day, all of them will spiral to come and insert on what we call the lateral lip of what we call intertubercular sulcus. This muscle, forming the bed of the breast, is what we call the pectoralis major muscle. Pectoralis major muscle. Yes, the key thing over here is that it is a hybrid muscle. Yes, why? Because it's having dual innervation. It is having, medial, pectoral nerve supply, as well as lateral pectoral nerve, giving it that kind of innervation. So that is, what I want you to actually know over here. Then, apart from that, if I cut and reflect, pectoralis major muscle deep to it, and then taking attachment from what we call rib 3, 4, and 5, back close to the costal cartilages, will be what we call the pectoralis minor muscle. Pectoralis minor muscle, and that pectoralis minor muscle, is going to insert, on what we call the coracoid process of the scapula. So this muscle, yes, what I want you to know over here is that it may be a hybrid muscle, because one thing is that normally it is supplied by medial pectoral nerve, but sometimes it may also receive some innervation from lateral pectoral nerve. If that happens, then it becomes a hybrid, muscle. So that's what I want you to know. Yes, I mean, this muscle, which receives some kind of nerve supply from what we call the spinal accessory nerve, cranial nerve 11. Okay, also gets some proprioceptive innervation from C3, C4, spinal nerve levels. Okay, this muscle actually originates from what we call the inion, that's the external occipital protuberance. Apart from that, the medial aspect of what we call the superior nuchal line. Then apart from that, yes, ligamentum nicae, and of course C7, spine of what we call C7, spinal spaces of C7, as well as, yes, all the spines of the thoracic vertebrae, Okay, that's how it's going to, that's the vast, that kind of origin. But at the end of the day, the point of insertion, yes, is going to insert in three main areas. Okay, it will insert that aspect, lateral third of the clavicle. Apart from that, the acromion. Okay, then apart from that, the spine of what we call the clavicle. Yes, so lateral third of clavicle, okay, acromion, and of course the spine of the scapula. That will be the insertion point. So we can divide the fibers into three areas, the upper fibers, middle fibers, and of course lower fibers, as illustrated over here. So that is what I want you to know. And then if you want to know the actions of all these things, yes, I've done those videos, but we'll be going through all those ones. But specifically, this question, we want to know the nerve supply, and the nerve supply over here is, apart from the spinal accessory nerve, okay, getting some proprioceptive, innervation, okay, sensing that through C3 and C4. But let me see this. However, in the case of latissimus dorsi, which of course you saw in the question, latissimus dorsi is never, supplied by spinal accessory nerve, but rather its nerve supply is coming from what we call thoracodorsal nerve. And we said that thoracodorsal nerve is not C5, C6, it's rather C6, C7, and of course C8 root values. Okay, please, you have to know this one. Okay, and this, latissimus dorsi, yes, let me just talk briefly about the kind of origin and of course insertion. Yes, it's originating from somewhere iliac crest. Apart from that, the thoracolumbar fascia will give it that kind of innervation, together with, of course, the spinal processes of C7 all the way to, of course, T12. Then, more importantly, yes, the lower 3 or 4 ribs, as well as, of course, the inferior angle. Yes, some of the fibers will be taking origin from the inferior angle of the scapula. But at the end of the day, yes, they wind around and then come all the way to insert on what we call the floor of what we call the intertubercular sulcus of the humerus, because between the two tubercles there will be a sulcus over the intertubercular sulcus, and that's why we have this mnemonic, a lady between two majors. Pectoralis major we insert on the lateral lip of intertubercular sulcus, teres major, the medial lip, and of course latissimus dorsi inserting in the floor of what we call the intertubercular sulcus, otherwise known as the bicipital sulcus. That is that one. So please get to know that this one, thoracodorsal nerve, is supplied by what we call the thoracodorsal nerve. Okay, and that root value is C6, C7, and of course C8. Then, so here is it again, showing you the where it's going to insert. Okay, having that kind of vast origin. You can see some of the fiber coming from the inferior angle. Yes, from the T7 all the way to T12. Yes, thoracolumbar fascia. Yes, even the the iliac crest. I told you that it is only the external oblique muscle which will be inserting on the iliac crest. Any other muscle which attaches on the iliac crest actually originates from this area. As well as the lower, this rib number, 12, 11, 10, and of course 9. So lower, 3 to 4 ribs. Okay, that's where it originates. Then we're going to insert in the bicipital groove or the intertubercular sulcus. So please note that. Then the other nerve which is actually supplied, okay, in addition to the trapezius by the spinal accessory nerve, is what we call the sternocleidomastoid muscle. So that's the sternocleidomastoid muscle, taking origin from, mainly, from the mastoid process of the temporal bone. Yes, coming to insert on what we call, it's actually originating. That's why we say it's having two hairs. Yes, coming from the medial aspect of what we call the clavicle, and of course, from the manubrum, okay, of the sternum, all the way coming to insert on what we call the mastoid process of the temporal bone. So this is what we call the sternocleidomastoid muscle. Yes, showing you the nerve supply by, of course, the spinal accessory nerve. So please get to know, out of the picture is what we call latissimus dorsi, but inside will be what we call the sternocleidomastoid muscle, as well as, of course, trapezius muscles supplied by, of course, the spinal accessory nerve. Now, looking at the spinal accessory, we talked about the relation. Now, an important relation which you should know, yes. Now, looking at the medial, now this is the scapula, okay, this is the medial border of the scapula, okay. Now, the medial border of the scapula, we can see three, muscles, inserting there, which of course will be, covered by, of course, the trapezius muscle. But if I cut and reflect trapezius muscles, I'm going to see three muscles. So, inserting, okay, at the medial border dorsally, okay, above the root of spine, is what we call the levator scapulae muscle. Then inserted at the root of spine will be, of course, rhomboidios minor, and of course rhomboidios major will be inserting below the root of the spine at what we call the dorsal medial aspect of the dorsal aspect of what we call the scapula. Now we see that two main nerves will be running along the medial border. Now what is happening is that if you are seeing the nerve running superficial to these muscles, okay, to these three muscles over here, then that nerve is what we call the spinal accessory nerve, the one which is going to supply the sternocleidomastoid as well as the trapezius muscle. So this is that nerve, spinal accessory nerve, okay. So it runs superficial to it, but running deep to it, and for that matter supplying these three muscles, levator scapulae, rhomboidios minor and major, will be this nerve. And this nerve is what we call the dorsal scapular nerve. And dorsal scapular nerve, its root value is, of course, C5. So we will see these things. Okay, so that is the important relation you should know over here. So as we said, in the back, okay, the superficial muscles that we are going to find over here, okay, is going to have two layers. We'll be arranging two layers. We have the first layer, and of course we have the second layer. Okay, now one thing you should know about the first layer is that the first layer is the most superficial layer. So in the upper aspect is the trapezius, in the lower aspect it is going to be what we call the latissimus dorsi we've seen. So if we cut and reflect this trapezius muscle, then deep to it, the second layer, there are those muscles that we saw, levator scapulae, rhomboidios minor, and of course rhomboidios major muscles. So that's what I want you to actually know. So there we are. Now this muscle, which we call it rhomboidios minor muscle. Now for rhomboidios minor muscle, yes, that one is going to originate from the nuchal ligament, and apart from that, importantly, C7 and T1. Okay, apart from the nuchal ligament, importantly, C7 and T1 spinal processes, and then it comes all the way that inferior laterally to insert on what we call the root of the spine, dorsal aspect of the medial border of the scapula. Then taking attachment from actually T2, because this one started from C7 and then T1. So from T2 all the way to T5, taking origin from the spinal processes, will be what we call the rhomboidios major, and that one inserts majority, yes, of that area of the medial border of the scapula dorsally, yes, is what we call rhomboidios major muscle. That's the insertion point. So get to know that the dorsal scapular nerve, its root value is actually C5, not C4, no, C5. Okay, so the root value is C5. Okay, and then there is another muscle which we've seen already. Yes, that one. Okay, taking attachment this time around. Look at it, it's not from the spinal processes, but it's from the transverse processes. Okay, laterally, transverse processes of what we call C1 all the way to C4. And then also coming inferior laterally to insert, okay, on the dorsal aspect or the medial border of the scapula, but above the root of the spine. So that is, the Levator Scapulae muscle. And remember, apart from being supplied by, of course, the dorsal scapular nerve, whose root value is C5, it will get some additional innervation from C3 and C4 ventral rami of the spinal nerves. So please get to, appreciate these ones. So just to give you some kind of, root values, you know these things. Yes, it's also very examinable. So for instance, we know that if you look at the brachial plexus, we have three, cords. Okay, coming from the trunks, we have three cords. And these cords, we have the lateral cord and with the mnemonic LML. Okay, so simply know the mnemonic LML. And L for lateral pectoral nerve, M for musculocutaneous nerve, and of course, under L for lateral root of the median nerve. The medial nerve will have two roots, lateral root of median nerve, and of course, medial root of median nerve. The lateral root will be coming from the lateral cord. Now remember, all of them, their root value will be C5, C6. So simple. If you go to that of the medial cord, okay, then what will happen is that we are going to have, 5, branches. 5 terminal branches. Okay, so these 5 terminal branches also with the mnemonic M4U. So M4U, there are 4 M's and 1 U. So the M's are medial cutaneous nerve of arm, medial cutaneous nerve of forearm. You can see all of them, both of them, their root values are C8, T1. Okay, please get to know C8 and T1. Then we also have medial root of median nerve. Yes, that's also C8, T1. Then medial pectoral nerve. Yes, C8, T1. So simple. Medial cord of the brachial plexus, C8, T1 mainly. Okay, but the ulnar nerve, okay, gets a communicating branch from C7. And so apart from C8, T1, the ulnar nerve will also have C7, okay, to be part of the root value. So please get to know that. Then we go to the posterior cord. Yes, posterior cord with a mnemonic star. Okay, that's also 5 branches at the end of the day, star. And star is for subscapular. Yes, the S in the star is subscapularis. Okay, subscapular nerve. But the subscapular, we have upper subscapular nerve and of course lower subscapular nerve. Both of them, okay, have root values C5, C6. So simple. And then we go to, T is thoracodorsal nerve or nerve to latissimus dorsi. And that's the one I told you. It's not coming from C5, C6. But rather, it's coming from C6, C7, and of course C8. Likewise, axillary nerve, just like upper and lower subscapular nerve, C5, C6. So simple. But radial nerve, yes, we'll be getting, yes, that nerve supply from C5, from C6, from C8, and of course from T1. So please get to know these ones. Okay, so C5, C6, C8, and of course, T1. So that is where the radial nerve, yes, is going to get, that kind of, innervation from. So that is that one. But actually, yes, C7, is supposed to be part of it. So C7 is actually supposed to be part of it over here for the radial nerve. So please get to know these things. And just to give you a small summary, if you look at the level of the brachial plexus and where these nerves are coming from, yes, it's also very relevant. Okay, so there's a table to give you some idea. So we have the level where the nerve emerges, the nerve, its root value, and of course its motor innervation as well as sensory innervation. Now, because I've already talked about the origin by way of root value, I'm not going to mention that one again. So if we look at the level of root, we have this nerve which comes out, which we call the long thoracic nerve, and that one, yes, actually innervates what we call the Serratus Anterior muscle. Yes, with root value C5, C6, C7. Dorsal scapular nerve, no C4, but rather C5. And that one will supply Levator Scapulae as well as Rhomboidios, minor and major muscles. So it means that these two muscles, they have only motor supply. Yes, there's some nerve supply coming from C5, and that one combines with that of C4 and C3, okay, ventral rami, to supply the diaphragm, and that's the sphenic nerve. Now from the trunk, we have 2 nerves which emerges there, and these ones are the suprascapular nerve as well as nerve to subclavius. Okay, both of them C5, C6 root values. And we know that suprascapular nerve, apart from supplying supraspinatus, also supplies infraspinatus, muscles. Then nerve to subclavius, the name suggests what it does. Okay, it supplies subclavius muscle. And then of course, if you look at the lateral cord of the brachial plexus, we've seen all these muscles. But one thing you should know is that the lateral pectoral nerve, which we've seen, will supply always will supply pectoralis major, but sometimes also supply pectoralis minor in case pectoralis minor becomes a hybrid muscle. Then for medial pectoral nerve, no problem supplying both pectoralis major and minor muscles. Then thoracodorsal nerve or nerve to latissimus dorsi, you know what is going to supply latissimus dorsi muscle. And then the subscapularis muscle, we have upper and lower subscapular nerves. And upper and lower, the upper supplies exclusively subscapularis muscle, but the lower, apart from supplying subscapularis muscle, also supplies teres major muscle. We will see in our subsequent question, we will be seeing all these ones. Then with respect to the terminal branches like the axillary nerve, C5, C6, their root value, apart from supplying deltoid muscle, also supplies the teres minor muscle. But it also has a sensory component which supplies the region which is the upper superior or superior lateral aspect of what we call the arm. So that's very important. Then the musculocutaneous nerve C5 to C7 root values, and that one supplies muscles of the anterior compartment of the arm, excluding the lateral third of the brachialis muscle. So that is what it does. Apart from that, it continues to become what we call the lateral cutaneous nerve of the forearm, therefore supplying the lateral aspect of the forearm. If you look at the radial nerve, that's the root value, and then that one will be supplying muscles of the posterior compartment of what we call the arm, the forearm, over there. So that's what we are going to see. But one thing that we find is that it also has some kind of sensory or cutaneous innervation as well. So it will supply what we call the posterior aspect of what we call the arm. Apart from that, to give some innervation to that of the lateral aspect. So posterior aspect of arm and forearm. Apart from that, what we call the lateral 3.5 of the dorsal aspect of the hand and digit. Yes, it will be coming from this area, excluding the nail base. So please get to know that it excludes the nail base. Excluding the nail base. So that's what we see. And then if you look at that of the median nerve, will be supplying majority of the muscles in the anterior compartment of the forearm and hand. But one thing is that apart from flexor carpi or ulnaris, that one will rather be supplied by the ulnar nerve. Then of course the medial half of what we call the flexor digitorum profundus, that one too. Then of course what we call the medial two lumbricals, they will also be supplied by, of course, the ulnar nerve. So that one will be the exception over here. So please, I've done all these things. Please visit those videos to get more insight in that. But we're looking at closer look at all these muscles in our future revision exercise. So what we find is that with sensory innervation, the median nerve supplies what we call the lateral 3.5 of what we call the palmar aspects of the hand and digits, including the nail base. Very important. Then if you look at the ulnar nerve, rather supplies the medial half of the dorsum of the hand. The medial 1.5 of the dorsum of the hand, as well as, of course, the palm area. So the dorsal aspects as well as the palmar area should be supplied by the ulnar nerve exclusively, including their nail base. So please get to know that. All right, so let's go to question number 2. And question number 2 says, which of the following is not true? Option A says stabilizing factors of the shoulder joint include the glenoid labrum, joint capsule, glenohumeral, and coracohumeral ligaments. Yes, that's a very true statement. Yes, we know that the glenoid labrum will deepen the articular facet. Yes, by way stabilizing, the joint capsule will do that, reinforce the joint. Yes, as well as these extrinsic ligaments that we find. They are very true, stabilizing point. That's true. Option B says The upper trunk of the brachial plexus gives the nerve to subclavius and subscapular nerves. So that is also a very true statement. Yes, nerve to subclavius, which we've already seen. Yes, that's a very true statement. Now option C says, although the musculocutaneous nerve supplies the muscles of the anterior compartment of the arm, the lateral third of the brachialis muscle is supplied by radial nerve. Yes, that's a very true statement. We know that the BBC muscle, they are muscles of the anterior compartment. Yes, namely bicep brachii, coracobrachialis, and of course, brachialis muscle. Those ones, yes, mainly are supplied by, of course, the musculocutaneous nerve. But the lateral third of the fibers of the brachialis muscle will not be coming from the musculocutaneous, but rather from the radial nerve, making the brachialis muscle a hybrid muscle. Now let's move on. Option D says honeymoon palsy is experienced from compression of the radial nerve in the spiral groove. Yes, that's a very true statement. Yes, honeymoon, palsy, which is very consistent. Yes, the same as that of, Saturday night palsy. Yes, if someone lies on your, let me say abducted, arm, then what will happen is that perhaps, yes, radial nerve will be compressed in what we call the spiral groove, leading to that palsy. Now, option E says one of the contents of the quadrangular space is axillary nerve. That's a very true statement. It's the axillary nerve. Yes, apart from that, the posterior circumflex, humeral artery will also be a content. So, with this, question, yes, all the statements, yes, are true. All the statements are true. Everything is true. So let's try and justify these ones. So you know that the frequently dislocated joint in the human body is what we call the gleno. Gleno, that's a glenoid cavity, humeral, joint. Okay, well, of course. Now, yes, always I say that, yes, although it is a frequently dislocated joint in the human body, if God had not added something, then the frequency of dislocations would have been more, because the head of the humerus is larger than the glenoid cavity. Okay, making that kind of possible, phenomenon that, yes, it's likely going to be dislocated. So God, in his own wisdom, yes, put in something over here, and that thing that was put in here, okay, is what we call the glenoid labrum. And that glenoid labrum is a fibrocartilaginous rim, okay, to deepen this articular, facet. So it tells us that, yeah, the glenoid labrum will be one of the stabilizing, factors over here. Now, because there's a ball and socket joint, and for that matter, a synovial joint, then it makes sense that there will be a joint capsule reinforcing this. Okay, reinforcing this. So the joint capsule, outer fibrous component of the joint capsule, will be very important component to help in the stability of this joint. Okay, so that is one thing that you should know. Now, apart from that, you see the other ligament, and one of these ligaments can be seen here. And this ligament is what we call the transverse humeral ligament. This transverse humeral ligament, it's not directly reinforcing this, joint. But one thing is that important things are stabilized over here. And one of them is what you call the tendon of the long head of the bicep brachii muscle, which runs in this bicipital groove or this intertubercular sulcus. Okay, but apart from that, even the anterior circumflex humeral artery, its branch, ascending branch of the anterior circumflex humeral artery, also runs over here. But not only the tendon, but the tendon also comes with its sheath. That becomes the tendon sheath. Okay, so the tendon sheath, and of course the bursae around this area will help, of course, minimize friction around this area. Of course, alongside, the joint capsule, alongside what you call the synovial membrane, also secreting what you call synovial fluid, okay, over here. So these ones are all, helping, yes, to minimize that kind of friction over here. So, that is, what we are talking about. That is the, we have the joint capsule, okay, the capsular ligament over here, trying to help stabilize this joint. There are some bursae around, okay, there's the subacromial bursa. Okay, the subcoracoid bursa. Yes, all these bursae are there, and then the tendons around these areas also have tendon sheets, okay, to minimize that friction. But some other ligaments which are very important, okay, in helping stabilizing, this joint, yes, we include this ligament over here, coracohumeral ligament. Coracohumeral ligament. Yes, so it tells you the attachment, coracohumeral ligament. Then, of course, yes, we've also seen, yes, there will be another ligament over here, okay, and that ligament, yes, it's coming from actually the tendon of what you call the subscapularis muscle, and that is why, you know, we talk about the rotator cuff muscles also providing stability to this joint. So rotator cuff muscles that we've already seen, yes, supraspinal twist, infraspinal twist, teres minor, and of course, you know, subscapularis muscle, yes, all of them will help in the stability of the joint. Okay, but there are other ligaments which may not necessarily, yes, reinforce this joint, and some of them will include what we call the coracoacromial, you know, ligament. Yes, it will also include what we call the trapezoid part of the ligament, and as well as the conoid part of the ligament, and that ligament is what we call the coracoclavicular. So from the coracoid process to the clavicle, so coracoclavicular ligament having two parts, okay, trapezoid part and of course conoid part. So that's what we are saying. All these things are helping in the stability, but these ones are not directly, you know, involved in that stability over here. Yeah, so you know that the brachial plexus, yes, will be coming mainly usually from the ventral rami of C5 to T1, but sometimes we say there could be prefix brachial plexus where it begins from C4 and ends at C8, and there could be a postfix brachial plexus where it begins at C6 and rather ends at T8, T2. So please note that variations. But in the normal anatomy, what we know is this, and for that matter, these are the roots. Okay, when the roots, okay, C5 and C6 roots, when they come together, we form the upper trunk, and of course C7 root stays alone with C8, T1 roots, yes, coming together to form the lower trunk. Okay, please note that. And then one thing that we know is that these trunks will divide into anterior and posterior divisions. So all the posterior divisions of these trunks will form what we call the posterior chord of brachial plexus, and then the anterior divisions of what we call the upper and middle trunks will come together to form the lateral chord. And then, of course, you know, the anterior division of the lower trunk will stay alone to become what we call the medial chord. Now, this nomenclature is based on their relation with, of course, the axillary artery. Please note that. And then, from the course, we get the terminal branches, which, of course, I've given the mnemonic, okay, for it. Now, one thing that we know is that if it is coming from the roots, there are only two nerves coming from the roots. And one of them is the dorsal scapular nerve, root value C5. Then coming from C5, from C6, and from C7, yes, run along the lateral wall of the chest or the thorax is what we call the long thoracic nerve. Okay, so there are two nerves coming from the root, but from the trunk we have also two nerves, and they are the suprascapular nerve and of course nerve to subclavius. Okay, so these are the things that I want you to actually know. So if you look at muscles of the anterior compartment of what we call the arm, yes, we have what we call the biceps, brachii muscle, having two hairs. One of its hairs being the short head coming from the coracoid process, and then the long head coming from what we call the infraglenoid tubercle, forming a common belly to insert. Okay, finally to insert on what we call the radial tuberosity. Okay, so there's one of them. If I cut and reflect this one, then dip to it, but rather taking attachment from the lower aspect of the shaft, okay, anterior aspect and anterior lateral, anterior medial aspect of the lower shaft of what we call the humerus will be what we call the brachialis muscle, okay, which inserts on rather the ulnar tuberosity. But taking attachment from what we call the coracoid process, but inserting, okay, at the medial aspect of the middle shaft of the humerus, okay, opposite to where the deltoid tuberosity is what we call the coracobrachialis muscle. Okay, now remember that all these three muscles are supplied by what we call the musculocutaneous nerve. Yes, as you can see over here, because that musculocutaneous nerve pierces this coracobrachialis muscle. Yes, once it's going to pierce it, it's going to supply it. Okay, and then also it supplies what we call some fibers, yes, go on to supply what we call the bicep brachii muscle as well as the brachialis muscle. But which portion? The medial to teres portion of what we call the brachialis muscle. Rather, the lateral one, third of the fibers of the brachialis muscle will be coming from what we call the radial nerve, making the brachialis muscle a hybrid muscle. So I mean, that is what I want you to know. But one thing again which you should know is that after this, I mean, nerve, musculocutaneous, has finished supplying, giving this motor supply, it continues as a cutaneous nerve. So it becomes the lateral cutaneous nerve of the forearm. So please get to know that. Yes, again, there are so many levels in which the radial nerve can be injured, okay, or can be compressed. Now, if it's injured or compressed, then you see that there will be that kind of, I mean, signs, okay, such that you will not be able to, I mean, perform very well with your extensors, okay. But one thing that we know is that, yes, classically, if you are having crutch paralysis, okay, crutch paralysis, if your crutches are not well aligned, okay, then what will happen is that radial nerve could be injured, okay, in the axilla, okay. That's what we call crutch paralysis. If what is happening is that if it is injured, okay, in the spiral groove, normally we call it sudden anal palsy. If someone get drunk, okay, and then rest the arm on a chair, then it could happen like that. The posterior aspect of the arm on a chair could happen like that. Also, if you go on honeymoon, or if a lady or whatever, if you lie on the arm of what we call the man, okay, in a lying position this way, and the lady lies, okay, on the arm this way, then radial nerve could be compressed in the axilla. Now we take time and look at, you know, the revision aspect of the radial nerve. We look at that one in detail. But what is happening is that because radial nerve wasn't injured in the axilla, yes, there may not be any problem. There will be weakness anyway in what we call arm flexion at the elbow joint. But what will happen is that there will be transient, because this one, yes, if you get relieved, then it's resolved. So there will be transient, you know, wrist drop, as well as, you know, finger drop. So you see that, as well as some kind of loss of cutaneous nervation, the lateral aspect of what we call the forearm, okay, and what we call the dorsal aspect of the hand area, okay. I mean, dorsal tree have sensory loss, okay, over that area. So you look at these ones in detail. So if there's injury in the, I mean, radial nerve in what we call the spiral groove, you may either call it Saturday night palsy or honeymoon palsy. So importantly, we have what we call the muscular spaces in the scapular region. So this one, yes, you just have to draw that of the proximal aspect of what we call the humerus, including the proximal shaft, and then of course you draw the scapula this way. Then we know that this muscle, which is teres minor muscle, yes, will be originating from, you know, the lateral aspect of what we call the scapula, and it will be inserting on what we call the inferior facet on the greater tubercle of the humerus. So there's the teres minor. Then teres major, on the other hand, lower aspect of the lateral aspect of the scapula, and it comes and inserts, okay, because teres major, a lady between two majors, medial lip of what we call the intertubercular sulcus. Then taking attachment, the long head of the triceps brachii muscle, coming from the infraglenoid tubercle all the way to, of course, joining with the other, hairs of the triceps brachii muscle to insert on what we call the olecranon, posterior aspect of the olecranon process. So if we are having this, then we are going to have, three spaces. And these three spaces, this one over here, this quadrangular shaped one, is called quadrangular space. Okay, quadrangular space. And therefore the quadrangular space will be bounded superiorly by, of course, teres minor, laterally by, of course, tendon of the long head of triceps brachii muscle. Then, of course, inferiorly by, of course, teres major. Then laterally by the proximal aspect of what we call the humerus. So this area is the quadrangular space, and the content, importantly, yes, axillary nerve as well as the posterior circumflex humeral artery will be content. So indeed, it's a content. Then we also have the upper triangular, space. Upper triangular space is over here, and this upper triangular space, yes, we see the, circumflex humeral artery as a content. Circumflex humeral artery as a content. Yes, that one too. Laterally, it will be bounded by, of course, the tendon of the long head of triceps brachii muscle. Yes, inferior by teres major. Then, of course, medially, okay, it will be bounded by, of course, the scapula together with the teres minor muscle. So its content is the circumflex humeral artery. Then there's another triangle over here. That's the lower triangular space, which is otherwise known as triangular interval. Okay, lower triangular space, and that one, it will be bounded, okay, superiorly by teres major, yes, medially by the tendon of the long head of triceps brachii muscle, and of course laterally by the shaft of what we call the humerus. And the contents are two, apart from, yes, the radial nerve and then the profunda. Apart from the radial nerve, yes, we also have what we call profunda brachii, artery, and of course vein will be there. And that is why if someone lies over here at the dorsal aspects, okay, then what will happen is that, the radial nerve could be compressed over here. So we go to our last question, and that is question number 3. And question number 3 says, which of the following is false? Now, option A says the biceps brachii muscle, which inserts on the olecranon process of the ulna, is supplied by the radial nerve, the largest branch of the brachial plexus. No doubt that the largest branch of brachial plexus is the radial nerve. Yes, because it supplies everything, everything in the posterior aspect of the arm and forearm. So indeed, yes, that's a very true statement. Option B says seen in the deltopectoral groove is the cephalic vein. Yes, that's a very true statement. Yes, at the end of the day, it has to pierce the clavipectoral fascia and of course drain into what we call the axillary vein. That's a very true statement. Option C says the cubital fossa has the median nerve as its medial most content. Yes, that's a very true statement. MBBR, I'll show you that. Option D says the brachioradialis muscle, which forms the lateral boundary of the cubital fossa, is supplied by radial nerve. That's a very true statement. Now, the surprising thing is that if you look at it, brachioradialis muscle, it's more anteriorly placed. Okay, so yes, we expect that if it's anteriorly placed, then it should be a flexor, and for that matter, it should be supplied, by either, mainly median nerve or maybe ulnar nerve. But the surprising thing is that it is rather supplied by what we call the radial nerve. Okay, yes, supplied by, of course, the radial nerve. So we will see that. Then option E says in the superficial fascia overlying the cubital fossa, the median cubital vein often accessed for, yes, in the superficial fascia overlying the cubital fossa is the median median cubital vein, often accessed for venous blood during venipuncture. Yes, that's a very true statement. So we will see that. So regarding this question, what is happening is that, yes, all of them, okay, all these statements, are correct. All the statements are correct. So let's justify that. So if you look at the triceps brachii muscle, the triceps brachii muscle is going to have 3 heads. Okay, then what will happen is that it's having what we call long head. The long head is coming from what we call the scapula. It's the only head coming from the scapula, and it's coming from what we call the infraglenoid tubercle of the scapula. So, and then we have what we call the spiral groove. Now, taking attachment above the spiral groove will be what we call the lateral head of what we call triceps brachii muscle, and below the spiral groove, a very large area below the spiral groove, and that one is overshadowed by the long head of the triceps brachii muscle, is what we call the medial head of the triceps brachii muscle. Okay, so that is what we see, but all of them will come and then insert in what we call the posterior aspect of what we call the olecranon process of the ulna. Remember that the ulnar nerve, the radial nerve is the nerve supply to the posterior compartment of the arm as well as forearm, and therefore that's the nerve supply. Okay, so please get to know that. So yes, if you look at the arm, which we will see that, yes, laterally placed we have the cephalic vein, and that cephalic vein ascends, yes, between this muscle where is the deltoid muscle and this pectoralis major muscle. Between them there's a groove which we call a deltopectoral groove. Okay, so cephalic vein is a content. It runs over here and then pierces what we call the clavipectoral fascia. So we will see that now it is not only cephalic vein which pierces the clavipectoral fascia, which and then eventually draining into what we call the subclavian vein, but also we also have what we call the the lateral pectoral nerve, okay, will also be there, as well as of course the the various branches of the thoracoacromial trunk, and those ones. Yes, APC dogs, A for the acromial branch, P for pectoral branch, C for clavicular branch, and then of course the dogs will be the deltoid branch. So all those ones will also be piercing through the clavipectoral fascia. So please get to appreciate that. If you look at the cubital fossa, that transition between the anterior aspect of the arm and of course forearm over here, that triangular area over here, cubital fossa. Okay, now this is actually more or less like a misnomer, so to speak. I'll explain. Because the posterior aspect, okay, of this area, which is where we can see the prominence of the olecranon, is actually the cubital aspect, and then this area is the antecubital aspect. So naturally we should have called this area antecubital fossa, but well, we are calling it cubital fossa. So this cubital fossa, yes, you can see this muscle which forms what we call the medial boundary is called pronator teres muscle. And then of course there's another muscle over here which forms the lateral boundary, which is called the brachioradialis muscle. And that's why we said this brachioradialis muscle is more anterior placed, and therefore we expect that it should have been supplied by, of course, the for instance, median nerve actually, but it's supplied by the radial nerve. So you see that. So over here, yes, between the two epicondyles, there's a medial epicondyle, very, very palpable. Okay, and then lateral epicondyle will be somewhere. So arranging from medial to lateral, the content of the cubital fossa, so MBBR, so M for median nerve, B for brachial artery, there's another B, that's the biceps brachii muscle tendon, then R for radial nerve. R for radial nerve, not very clear here, but the radial nerve will be the lateral most content. Now because these two components are the medial most content, that's the median nerve and brachial artery, that is why they are frequently involved in compression over here. And that compression, we call it, that syndrome, we call it Strutter's syndrome. The reason is that if you look at about 1% of the population, that's why we tend to see it in bears. And that's why frequently we call it, avian spare. So on X-rays, sometimes we see it in about 1% of the population. This one is called supracondylar, spar, or something we call supratrochlear spar, because it is above the trochlear. So supratrochlear spar. But there's a ligament which attaches it from this medial, condylar spar, okay, or this supracondylar spar, okay, all from here all the way to what we call the medial epicondyle, therefore creating a tunnel over here which two of the medial content of the cubital fossa runs, and those ones are median nerve and of course the brachial artery. Okay, so these are the things which you should actually know. So that's the brachioradialis muscle. It actually takes attachment from the proximal aspect of what we call the lateral supracondylar ridge. Okay, and then it comes all the way to insert on what we call the styral process of what we call the radius. Okay, so that is that one, supplied by, of course, the radial nerve, forming important component, forming the lateral boundary of what we call the cubital fossa. So there are a lot of veins, there are a lot of plexus of veins in the arm area, that transition around the cubital region, okay, of the arm and of course forearm area. So one thing that I want you to know is that get to know that all these veins, okay, when they meet, okay, over here, actually in what we call the superficial fascia, these veins will be found in the superficial fascia. If I take off the skin deep to it, I'm going to have the superficial fascia. Okay, when they combine, we form what we call the median cubital vein. Okay, that's the one where it's often accessed, for venous blood, urine puncture. But one thing that you have to know is that anything which has to do with the arm is called brachial. It has to do with brachial. And then anything that has to do with the forearm will be antibrachial. So please get to know these terms. So if the thing is lateral, okay, more laterally placed, then that vein becomes cephalic. If it's medial, then it becomes basilic. Okay, so assuming we have the medial epicondyle over here, very palpable. Yeah, then what we are saying is that yes, we expect this to be the basilic vein of the arm, basilic vein of the arm, or the brachial, basilic vein. Then this one becomes the brachial cephalic vein. Now look at this. Deep to them, deep, very deep. are two of the medial content of the cubital fossa. So you can see we have what we call the median nerve, and of course we have what we call the brachial artery. So please get to know that this especially the median nerve will be very important, so that I will describe something to you. So over here I have the basilic vein of the arm. Okay, then I have what we call the cephalic vein of the arm. Now, if once I'm getting a branch, okay, of this basilic vein, as it gets closer, okay, medially, sorry, as it gets, a bit lateral, let me say that, as it gets closer, because the basilic vein is, medial already, as it gets laterally closer to this median nerve, then the name becomes what we call median basilic vein. So it gives a branch, the basilic vein gives a branch, which we call it the median basilic vein, laterally, which is very closely related superficially to the median nerve. Then, on the other hand, when this cephalic vein gives a branch medially, okay, very close to this median nerve, then it becomes median cephalic vein. Median cephalic vein. So as you can see, median cephalic vein and of course median basilic vein, they are joined over here. They have this communicating channel over here, and that is what we call median cubital vein. Now, similarly, if you are from the area of the the forearm, then more medially placed will be the basilic vein of the forearm. Basilic vein of the forearm. Similarly, we will have what we call the cephalic vein of the forearm. Okay, we will also have cephalic vein of the forearm. But the point is that this cephalic vein gives a branch. Sorry, cephalic vein is supposed to be gives a branch over here. Sorry, it gets a tributary over here, or it's a tributary of this inner aspect. Okay, getting closer to, of course, this median nerve, and that is what you call the median cephalic vein of the forearm. Now remember, veins have tributaries, not branches, so they are rather draining into this one. So the lateral one, okay, draining, okay, into, of course, the median cephalic vein of the forearm. Similarly, the basilic vein of the forearm drains, okay, into what we call the median cephalic, sorry, median vein, okay, sorry, median basilic vein. Okay, so as you can see over here, median basilic vein. Median basilic vein. So over here, what we are finding is that you can see this one, there's the median cephalic vein of the forearm, median basilic vein, okay, of what we call the forearm. Okay, both of them are also going to join over here. So all these median veins, okay, with respect to this nerve over here, where is the median nerve, they are all coming to join over here at the median cubital vein. Median cubital vein. So please get to know this. Let me use another some. So for instance, if I have the skin and I cut through this, then deep to it, I'm going to have the superficial fascia, and the superficial fascia will contain these veins. Okay, and then these veins, as I said, this one is the cephalic vein. Okay, laterally, cephalic vein of what we call the arm. Then we have what we call the basilic vein of the arm. Then similarly, we are also going to have the cephalic veins and then the basilic veins of the forearm. But what happens is that they will join, yes, around where we have the mid area to form. Okay, this joint connection between them is what we are calling the median cubital vein. Now these one, they have variable course they vary from individual to individual, so you have to study it carefully whenever you are doing venipuncture. Yes, you have to really know the veins that you are going for. But what we are saying is that there's a connection between the superficial veins and the deep vein, and that is what we call the perforating vein. The perforating vein. Then yes, so on the skin you can see these veins over here. So that vein which is frequently accessed percutaneously, okay, during venipuncture, okay, to get that kind of venous blood for various analysis, is what we are calling the median cubital vein. Okay, I've told you that this fossa, yes, it may rather, we should have actually called it the cubital fossa. By any case, that is it. So I hope you find this video helpful. yes, we'll go with the part 2 and then look at the other important aspects regarding the upper limb. I hope you find it helpful. Have a good night and may God richly bless you.